Welcome, everyone. My name is Masha Zaldonis. I am the Administrative Program Coordinator at the Down Syndrome Association of Pittsburgh. This is the first of our 3 Lunch and Learn speaker series with the Down Syndrome Center of Western PA. So we're really excited to be partnering with them for the speaker series on topics related to Down syndrome. And today we have Dr. Vellody with us, and he'll be presenting Lab Interpretation in Down Syndrome. Take it with a grain of salt. And with that, I will take it over and give it to you, Dr. Vellody.
All right, great. Thank you for inviting us to be a part of this Lunch and Learn series. For those who are online, there is a fun and actually will make this a lot more interactive way to participate today using an app called Poll Everywhere. So you just have to either text my last name to 22333 or go to pollev.com/Vellody, as you see here on the screen. And then there will be questions that will come up, totally anonymous, and nobody knows what you're answering. But it's a way for you to participate in today's talk. The reason for this talk, when they reached out, this is actually somewhat of a newer talk for me to put together, but it's one that I felt was going to be very helpful for our families because I get a lot of questions on the lab results. They come up in the phone app and they come up with different colors and exclamation points, and what do you do with those? And so that is why I thought I would put this talk together for us. So people are already starting to answer, which is great. But if you don't mind, go ahead and answer this first question, which is, what is the age of the loved one you're here representing on this meeting today? So again, the ways to join are there at the top of the screen, and then go ahead and just text in your answers as we go through. And just so the first one is just so I know who I'm talking to in terms of the age of the person that you're representing. So wonderful as people start to figure out the tech. If it doesn't work for you, that's fine. But this is just a nice way to kind of keep us interactive. Okay, so we are going to be using this case scenario throughout the entire talk. So this is going to be a 5-year-old with Down syndrome who has actually not been seen in the Down syndrome center since they had an initial visit as a newborn, which of course is not our ideal, but it does happen. And he's been seen by the PCP for annual visits, and there's been no reported concerns. But when the family asks the PCP, they describe that they are not entirely familiar with the AAP healthcare guidelines for kids with Down syndrome. So the family then made this appointment to see the center again, to see if there was anything that was recommended from a Down syndrome screening perspective, even if their child has been doing well and has been asymptomatic up to this point. So I want to just start off really actually with just this idea of, is going to a PCP, quote unquote, enough when it comes to following the healthcare guidelines? We have some really great PCPs here in the area, many of whom I've trained in my 20 years of being here in Pittsburgh. But what we discover just as national data was a few articles that have come out, and actually I think even a few more have come out since these, that have all pretty much said the same thing when it looks at how do pediatricians, how good are they in the community in following the healthcare guidelines? And all of those studies that I just showed you show that there's a really wide variability. Like people, the PCPs, as much as they want to be adhering to the guidelines, really have a hard time with that. But if you ask the PCPs in these studies, about 80% of them say, oh yeah, they're very comfortable with the guidelines. But the reality is when they are asked questions, like some of the ones actually that we're going to go through today will probably be very similar to what they were asked. They have incorrect responses. So the vast majority incorrect responses, especially when it comes to the most recent updates that have come out in the guidelines in the last 10 to 15 years or so. And so when we look at kids in general with Down syndrome, if they are just going to the PCP alone, really only about 13 to 17% have actually completed all of the healthcare guideline recommendations, which is obviously, as you might imagine, a very small percentage and nowhere near where we would want to be for the optimal health for people with Down syndrome in this country. So let's look at this question. Take a moment to either go to pollev.com/Vellody or to text the name Vellody to 22333. And you can answer either by text or online, whatever's easier for you. And go ahead and start to input your findings there. So we're getting a pretty good split here between all of the above. There we go. We got another couple coming through. Very good. And I do want to commend all of you for participating because, like I said, it does help me as well to know kind of what to address. And the way that the question is being answered right now is very similar to probably how the PCPs in those studies would have answered as well. Because if we were answering this question back in, I don't know, 2001, the answers would be similar to what you're putting in when it comes to things like cervical spine X-ray or celiac screening. Those were recommended for everybody with Down syndrome. But that update in 2011 actually took those out in terms of being a recommendation for asymptomatic children. So A and B are actually not correct in this 2024 where we are today. Nobody put leukemia screening, which is exactly right. There is actually, and we'll talk about this in a few slides, there's no such thing as leukemia screening in the way that we might think of thyroid screening, for example. And like I said, we'll talk about that. So really the correct answer, which 25% of you answered, is thyroid function testing is the right answer in terms of this list, what should have been done for this child before this age. So let's look at thyroid labs and how to interpret them. So there are going to be a variety of different versions in terms of the lab results that come back. So this is the first version. The thyroid results that we get in this case are that the TSH is high at 85.4 and the free T4 is low at 0.5. So I put the normal range there in parentheses and the results that the child got. So here's your next question, which would be, and I put the labs on the question as well, is how would you interpret these thyroid labs? So the TSH of 85.4 and a free T4 of 0.5. What is going on here? So go ahead and answer those. Hopefully the question updated on your screen, and you can go ahead and start to answer. Good. I'm glad I'm seeing these answers as they're coming up. They're again varied all over the place, which is helpful, very helpful for me to know kind of how to address. So I'm going to give you just a couple more seconds here to guess. You don't have to you don't have to know that you're right. Like I said, I don't know who's answering and how you're answering. This is all I see on my screen too, is just the graph. So feel free to answer. And so a little more than half of you felt that the result was normal. And then the next most common was underactive thyroid, and the next most common is overactive thyroid. And this is a hard thing to do when you're a parent is trying to understand, it looks like if we look at these results, remember the TSH was very, very high compared to the normal high, which would have been 5.31. And the free T4 is low compared to the normal low, which is 0.8. So we have a high TSH and a low free T4. And actually, that is the diagnosis of hypothyroidism. So those of you who answered B, underactive thyroid, are correct. So let me explain why that happens. And so you're going to see two things side by side here that I hope will help to make it easier to understand thyroid function and how, when it goes out of whack, why the labs do what they do. So if you notice here in the brain, there's a area called the hypothalamus, and then right below that is another area of the brain called the pituitary gland. So the hypothalamus sends out a hormone called TRH, and it goes all the way down the field right here to the pituitary gland. So it's a very short distance that it has to travel for this TRH to get to the pituitary gland. When it gets to the pituitary gland, what it does is the pituitary gland releases what's called TSH. Now we're starting to see letter acronyms that sound familiar to what we see in lab results as they come back for your kids and for our patients. And so the TSH is now released by that pituitary gland, and then that TSH goes to the thyroid gland, which lives in our neck. And the thyroid gland that lives in our neck is what creates the thyroid hormones that do all of the work that the thyroid is supposed to do. And the majority of the hormones that get released by the thyroid gland are actually what's called T4. And then a small amount of it is T3. And the interesting thing about that is T3 is actually the one that is the active version of thyroid hormone. T4 is not as active. The reason why our body releases more T4, though, is it lasts longer in the bloodstream. So what has to happen is when the thyroid hormone, the T4 or the T3, when it gets to our organs in our organs actually have this thing called iodinase, which makes the T4 turn into T3 and make the the actions of the thyroid hormone happen. And then, remarkably enough, that T3 goes back to the pituitary and says, hey, we've got enough of me around. Let's stop making as much TSH. So this is a very well coordinated, generally very well coordinated um, hormonal response where the ultimate product that is made, the T3, not only does the job, but also shuts down the upstream impact. So I hope that makes sense to some extent for everyone. Again, we're going to be looking at what happens when those things don't work. So specifically with hypothyroidism, we see in people with Down syndrome that they can be born with hypothyroidism. The babies are born at about 1 to 1.5% of babies with Down syndrome will be born with hypothyroidism right off the start. And you might think 1%, that's not that big of a number, but when you compare that to the typical population, those babies who do not have Down syndrome, this is actually almost around 30 times the rate of the rate that we see for congenital hypothyroidism or those born with hypothyroidism. So it's much, much higher in babies with Down syndrome. And then even if they don't have it when they're born, they can acquire it later in life. And this is usually an autoimmune attack on the thyroid gland in the neck. So it's got a interesting name called Hashimoto thyroiditis. All that means is that there are antibodies in the bloodstream that are attacking the thyroid gland. And you can actually send labs looking for those specific antibodies, and they're called thyroid peroxidase or thyroglobulin antibodies. So and then if they do have hypothyroidism, it really is best if it can be managed by a thyroid specialist, like somebody who's an endocrinologist, because especially for our patients with Down syndrome, they can sometimes change back and forth between underactive and overactive, especially early in the diagnosis. So having someone who's specialized in managing that is really important. So we here at the Down Syndrome Center, through our screening, will often pick up somebody who has a thyroid issue, but then we end up maybe initially starting therapy, but then sending them to endocrinology for further care. And that's why, is because they can have very different lab values, especially early on in their care. So when we look at the symptoms of hypothyroidism, there are several that look almost like what we see in people with Down syndrome who have normally acting thyroid. In fact, before they knew about chromosomes, and the reason why people have Down syndrome having one extra chromosome 21 is they used to think that it was actually caused by thyroid, underactive thyroid, because so many of the things on the list are very similar to what we see in people with Down syndrome in general. So that's just a little historical point. So as we look at when we're talking about underactive thyroid, that antibodies against the thyroid gland, I kind of added a little bit to the picture here. I put a few antibodies. You know, these are what circulate in our bloodstream to fight off infections and to do the work of our immune system. But unfortunately, when somebody has autoimmune thyroid issues, this just means that their immune system is now fighting against its own thyroid gland. So what would happen here is that the thyroid gland starts to not function anymore because the antibodies are destroying it. And because of that, we don't see as many thyroid hormones being produced, which means that the actions on the target tissues are going to be decreased because there's less thyroid hormone to do the work that needs to be done. And then that feedback loop, because there's less thyroid hormone in general, that feedback loop is also diminished. And so the pituitary thinks we know or recognizes we don't have enough thyroid hormone in the body, so it'll increase the TSH in compensation. So I hope that this makes sense in some way. When those antibodies destroy the thyroid gland, the ultimate effect is lower thyroid hormone, which means more TSH being produced by the pituitary. Almost like I think about it like a thermostat. You know, when your house gets cold in the winter, your thermostat kicks in to bring more heat, and this is the same idea. When your body has less thyroid hormone because of this autoimmune attack, your pituitary increases its production of TSH to try to kick in more production. But unfortunately, that's not going to be able to keep up for very long because the thyroid gland is being destroyed by those antibodies. Okay, so keep some questions in your mind that we'll get to here at the end. If you have any questions about anything we're talking about today, we can certainly try to answer those here at the end. Okay, so this is another version of what could have happened to this 5-year-old who showed up and got these labs at the Down Syndrome Center for the first time in a long time. And these thyroid results show the TSH is low and the free T4 is high. So here is your question to answer. So go ahead and pull out your phones and begin answering these as well. Don't give up. Keep trying. There we go. We got most everyone so far who have answered thinking hyperthyroidism. I'll give you just a couple more minutes to pull up that website or text your answer to that 22333 number and good. All right. We'll go with this so far. Feel free to keep answering if you'd like as I talk through. But again, don't worry about being wrong. It's okay if you're right or you're wrong. That's not the point of this. The point of this is so that we're all learning together. So very correctly, nobody thought that this was normal results. These results are definitely not normal. And we talked about hypothyroidism earlier. So good process of deduction. That is not going to be that answer again. And 75% of you are saying that this is an overactive thyroid, and you would be correct. This is the opposite of what we just saw. This is an overactive thyroid. And so that is called hyperthyroidism. And most of the time in people with hyperthyroidism, it's again another type of autoimmune attack on the thyroid gland, but this time those antibodies actually overactivate the thyroid gland. It's a different type of antibody that rather than kill the thyroid gland, it promotes the thyroid gland to make more thyroid hormone. And this is still very rare compared to hypothyroidism. This is still very rare for us to see in our patients with Down syndrome. Less than 1%, 0.66% of people with Down syndrome will get this Graves' disease or autoimmune hyperthyroidism, but still far more likely than in the general population, which is 0.02%. So definitely more common. And the diagnosis is going to be confirmed by, again, sending an antibody specifically looking for what's called the TSH receptor antibody, or TRAB. And that antibody is the one that activates the thyroid gland. And this definitely requires endocrinology management once the diagnosis is made. This is not one that should be managed by a primary care doctor, or certainly even not by us at the Down Syndrome Center. Our symptoms are almost the opposite in many ways to what we saw with hypothyroidism. In this case, we're going to see things like diarrhea, clammy skin. We still will see issues with weight gain and growth, and certainly some issues with the hair, as well as heart rate changing from not being so slow, but actually being a high heart rate. And that can actually be one of the clues that we'll see that we should be suspecting hyperthyroidism. Is that's a very common thing that we see. So let's look at this picture again, but this time looking at Graves' disease. Now we've got a different kind of antibody. Maybe I should have made that a different color even to show, but it's a different kind of antibody that rather than shutting down the thyroid gland is going to overactivate it, which means that it's going to overproduce the thyroid hormones, which is going to give too much activity to the target tissues like the heart. It'll make the heart race like that. We talked about the sweat glands. It'll make you clammy, those kinds of things. But the same thing, that T3 goes back up. And rather than what we saw before, this is actually going to suppress the pituitary, because the pituitary is going to see a lot more T3, which is going to make it think that we have too much, which is going to suppress the TSH. So this is why we're going to see in hyperthyroidism or overactive thyroid, we're going to see a low TSH and a high T4. And so that's why we see that here. Now, this is the third version. I'm not going to have you do a poll everywhere for this one because it would be pretty obvious which one it is now that we've answered the other two. In this case, what we're seeing is that the TSH is elevated slightly to 8.4, but the free T4 is normal. And what this is a very interesting situation that we call either subclinical hypothyroidism or compensated hypothyroidism, or if you really want a tongue twister, you can also call it hyperthyrotroponemia. But any one of those means the same thing. And depending on the definition that you use of the TSH level that would qualify someone for this diagnosis, anywhere from 7 to 40%, depending on which way you look at it in the data that's been studied, will have this at some point in their life with Down syndrome. The most common definition that's used, which is the one we also use as well, is where the TSH is high, but it's less than 10. So we saw like the normal range usually is around 5.5 or so. So between 5.5 and 10 means it's high, but not so high. And the T4 is normal. So what our approach is, which is very similar to other centers around the country and what our endocrinologists do as well, is that we would repeat those labs and then also send those thyroid antibodies in about 3 months. And then if most of the time, those labs actually return to normal in 3 months. And so that's actually, I would say, the vast majority of the lab results that we get. But there is a possibility that later they could develop hypothyroidism, which is why we make sure to check it in 3 months, because they could very well be early developing in hypothyroidism. So either normal or early hypothyroidism, we don't know unless we repeat it, which is why we repeat those labs in 3 months along with the antibodies to see if they have any kind of antibody attack against their thyroid gland. There is no evidence to start treatment for subclinical hypothyroidism unless they truly develop, true hypothyroidism. And this is an area where, Google is not your friend. There are a lot of, try to say this in an appropriate way, but a lot of people who practice medicine that's not necessarily so evidence-based who will recommend treatment for this condition with a thyroid hormone. And that's just definitely not the recommendation that we follow. Okay, so that's it for thyroid. So again, store up your questions, and when I finish here in a little bit, we're gonna have a time for you to ask those questions. Okay, now we're gonna look at blood counts. Okay, same child, 5 years old, comes in. Now, there's a lot on a blood count. Anyone who's ever opened up their my CHP or those things, you've discovered there's a lot of labs that will come back. And so I'm not going to be able to do service to every single lab, but I do want to draw a highlight to some of the more common ones that we'll get calls about in the center that are of concern that for the families, but sometimes not as concerning to us as doctors. So this first lab, it shows that the white blood cell count is low. It's at 3.7. And normal is 4.5 to 14.5. And so here's your question that I'd like you to answer. Okay, so again, pull out your phones and start answering these questions, which would be, how would you interpret this white blood cell count of 3.7? And make your best guess. There's, like I said, no way, no one's going to tell you if you were wrong or not wrong or whatever. So take a look at it. And good, we're getting a good response here. And keep going. Couple more seconds before we move on. So good. So we are very mixed in this response as well. And I hope that as we go through these labs that we'll be able to start to see a better understanding of all of how these labs work. The answer to this one is that this is actually normal for people with Down syndrome. And let me explain why. So this is what we call leukopenia. Leukopenia is just a medical way of saying low white blood cell count. And this is very common. in people with Down syndrome. In fact, when you look at studies that look at the lab results for people with Down syndrome, the white blood cell count is typically 30 to 40% lower than in the general population. So that's a pretty significant amount lower, and actually, in fact, very similar to what we just saw with this person's white blood cell count being 3.7. So unless there are other findings on history or exam, leukopenia, or a low white blood cell count by itself, is really usually not of concern and usually not an issue when it comes to increased infection risk or anything like that. There are several theories as to why people with Down syndrome might have a low white blood cell count. One of those is that when people with Down syndrome have, anyone actually, any child has a cardiac surgery, which is more common in kids with Down syndrome, obviously, because of the cardiac issues that we see, the thymus, which is not the thyroid, the thymus, which is a gland that lives on top of our heart, that is a part of our immune maturation. So when you're a child, your blood cells, your white blood cells, go to the thymus to mature. But the thymus sitting on top of the heart makes it really hard to do heart surgery, you could imagine, because it's a big glob of stuff on top of the heart. So it's actually removed during cardiac surgery. So there is one theory, which actually I think is a good theory, that shows that maybe removing the thymus automatically will lower that white blood cell count. There also is a lot of data to show that people with Down syndrome have higher levels of inflammation in their body. This is actually being well studied in different centers across the country, and looking at how um, when somebody with Down syndrome is doing well medically, if you check their inflammatory markers, they tend to be high. And many of these inflammatory markers are what um, uh, will indirectly actually lower your white blood cell count. You see, it's actually the opposite of what you might think. Sometimes we think inflammation will give you a high white blood cell count, and that happens with like bacterial infections and things like that. But with viral infections, or this particular type of inflammatory molecule we're talking about, it actually lowers your white blood cell count. So both of these are theories, maybe they're both correct, as to why we see lower white blood cell counts in people with Down syndrome. Okay, now we're going to look at the same patient again, different labs. This time the white blood cell count is normal, but a specific type of white blood cell count, called the neutrophil, is low. It's 22%. So what that means is that a lab tech looks under the microscope at all of the white blood cells, and 22% of those white blood cells are what's called neutrophils. So these are a subset of what type of white blood cells do you have. But 22% is low, and when you multiply 22% times the 4.7 white blood cells, or 4,700 is actually what that turns out to be when you do the math. It comes out to a low what we call oh, I'm sorry. It should say ANC. I apologize. I'll fix that slide. It's absolute neutrophil count, ANC, not ALC, ANC. But this is what I'd like you to answer is, how would you interpret now this blood count where the neutrophils are low in this person? So far, we're on the normal expected route. Anyone else? Any other thoughts? Okay. Well, those of you who answered, you have answered correctly. That this is actually normal or expected in people with Down syndrome, particularly young people, less than 6 years of age. We see a low neutrophil count, and it's in that age range, about 30% less than in the general population. And again, just like we were talking about low white blood cell counts in general, the low neutrophil, which a neutrophil is a type of a white blood cell, a low neutrophil count is typically not of concern. So now this is the same set of labs, except this time it's the lymphocyte count that's low. And I'm not going to have you answer the question, even though it may pop up, because I think you're all getting the sense this is normal again. This is what we call lymphopenia, which is again a type of white blood cell, which typically can run low in people with Down syndrome, actually 50% less even than the general population. And again, unless there's any findings on the history or exam that this person's been having recurrent infections or something like that, this is typically not of concern. Again, the same theories that we were talking about earlier. Okay, let's switch now from the type of white blood cells. Now this patient comes in and has one value that shows up as abnormal, and it's something called red cell distribution width. Okay, and it's a little bit higher, 16.5. So let's take a look at what you all think is the possible reason why this RDW might be 16.5. And you may have no idea, and that's okay. That's why we're talking about it today. But I kind of want to get a sense of where people are to start. So go ahead and give us an answer, even if it's a guess, an answer for what you think the RDW of 16.5. Good job, brave souls. Any other brave souls out there? There we go. I knew someone would jump on the normal or expected wagon because I've been going down that path for a long ways. So, um, so good. So about 67% of you are thinking this is possible iron deficiency, and that is correct. Now, let's look at each of these areas individually. So the first thing that I want to look at is hemoglobin. Hemoglobin is a measure of it's a molecule that carries our oxygen in our bloodstream. So when that is low, that's called anemia. In this case, the child is kind of borderline, but still within the normal range, which is why it didn't flag as red. The MCV, which is also called mean corpuscular volume, but everyone will call it MCV. MCV tends to be low if you have iron deficiency. Now, notice this child is like borderline, but not quite in the abnormal range. And the reason I want to highlight that, I think I talk about it in the slide here too, is that for most people with Down syndrome, for reasons that are not understood, they usually run high on the MCV. So if you were trying to diagnose iron deficiency in somebody without Down syndrome, you can rely on that MCV. It'll be low when they have iron deficiency. But if you have a child with Down syndrome, then let's say they started at a range of around 90 something, where their MCV would normally be on the higher end of normal, and then they became iron deficient because of whatever reason, they may not ever flag as abnormal in the MCV. So you need to remember that MCV may still be in the normal range because they started higher and then came down, but it's not going to flag by the lab because they don't know that they started off higher because they had Down syndrome. So I hope that helps. And then red cell distribution width, just as a matter of the way that the computer decides how many red blood cells, the things that carry our oxygen, how many are big, how many are small. If there's a lot of big and small together, that would give you a bigger wide distribution width. So some are small, some are big, and that's what we see in iron deficiency. So if I got these labs back, I would not be myself focusing so much on what they called normal. I would be thinking this MCV is low for somebody with Down syndrome. And this hemoglobin is actually low for somebody with Down syndrome as well. They tend to be a little higher there. So something's not right, and the RDW is a bit wide. And so what I would do in this situation is I would look at the specific iron labs, and you may have seen us order things called ferritin or TIBC, total iron binding capacity or transferrin. I'm not going to go into too much detail, but a low ferritin is consistent with iron deficiency, and a high TIBC and a high transferrin also consistent with iron deficiency. So this child does have iron deficiency and would benefit from iron replacement. We see more iron deficiency in people with Down syndrome. We're not exactly sure why that is. Maybe it's picky eating, texture aversion type things that we can see in our patients, that maybe they're not eating as many green leafies as they probably could or should. Maybe they have celiac disease, which is more common in Down syndrome, and maybe they're not absorbing iron because of celiac disease, which is definitely something that can happen. Um, and then, like I said earlier, the lab values, it makes it harder to diagnose it because the normal ranges really are going to be different in somebody with Down syndrome because of where they start, and where iron deficiency would bring them down to may not flag as abnormal in the lab. So it really takes somebody with a trained eye to look at those labs that don't highlight as abnormal. Okay, we're going to finish, I think, looking at the blood count, looking at this patient. This patient's lab is perhaps the most scary of all of the labs that we would look at today. This is a child with a low white blood cell count, a low hemoglobin level, and a low platelet count. These are all things that our bone marrow produces, and this child has them very low, meaning the bone marrow is not producing. But what the bone marrow is producing is blasts, or sometimes the lab will call them other cells. This is unfortunately a CBC that would fit with something like leukemia. So, parents often will call and be worried if one of the labs is off, like we were talking about with the white blood cell count being low by itself and that kind of stuff. Does this mean leukemia? And it almost always does not. But if many lines are down, the white blood cells, the hemoglobin, the platelet count, and there's things called blasts or whatever, that is very much concerning for leukemia. And we do see leukemia more frequently in people with Down syndrome. It is still rare, but especially in those first 5-ish years of life, that's when the highest risk is. And there are two main types that we can see. One is called AML. And there's a specific type of AML that we see in Down syndrome called MLDS, or myeloid leukemia of Down syndrome, MLDS. They are very sensitive to lower dose chemotherapy and 80% long-term survival, which is much better than the typical population with AML. And then ALL actually is not as favorable as it is perhaps in children who don't have Down syndrome, because the kids with Down syndrome have more toxicity to the chemotherapy. And so they both have about an 80% long-term survival. That 80% is a good number for AML compared to the general population, but not so great a number when it comes to the fact that 95% or so children with ALL without Down syndrome do well. Only 80% of children with Down syndrome will. So again, not a common diagnosis for us to make, but certainly more common than it would be in the general population. Okay, let's look at celiac labs. I'm not sure why this annotation, this red mark is there. Somebody, but anyhow, I didn't put it there. All right. So in this case, now the labs, you got back from the family. They were all looking normal, but then the child's parent calls because she notices you didn't send the celiac screening, and now the PCP has to draw labs again because you forgot to check the celiac labs. And so now you review your chart and you realize that the child was growing well. There really were no concerning GI symptoms. So let's answer this question and take a moment, because I know that the answer choices can be a little bit wordy, but give your best guess as to when should celiac disease screening be done. Okay, so I got rid of that mark there while you guys were answering. And so we are looking at after 3 years old, but only if symptomatic. But actually, the correct answer is after 1 year old, but only if symptomatic. So this is a change. The right answer, 15 years ago would have been B, for everyone with Down syndrome between 2 and 3 years of age. But actually, the answer now is only if they are symptomatic, and starting at 1 year of age is the low end where we would be checking. So let's look at this. And this is the same child, but now they do have symptoms. Okay, they have loose stools and bloating and decreased appetite. And they did have a celiac screening at 2 years of age that was normal, that the PCP had done, but still this child has these symptoms. So you repeat the celiac labs, and what we discover is that we get two labs as part of that celiac screening: the IgA and the TTG IgA. Now, the TTG IgA for this patient is very abnormal, and that less than 15 is normal. They are very elevated to 150. So this would be very suspicious for celiac disease. Now, the celiac antibody that we send is so there are multiple different types of antibodies that our body makes. One of them is called an IgA. IgA can be deficient in people in general, meaning you don't make any IgA at all. So a celiac screening in somebody with with total IgA deficiency would be inaccurate because even if they did have celiac disease, their IgA level is already low, so their TTG IgA level will also be low, even if they have celiac. But in somebody with a normal IgA level, which is what this child has, and an elevated TTG IgA, when you test that specifically, this is very suspicious for celiac disease. So this is a celiac disease is just a sensitivity to gluten because of an antibody attack on the intestinal cells. So you can see here in this picture that the healthy cells have these finger-like projections called villi. But in somebody who has celiac disease, they're all blunted. They've all been destroyed by the immune attack. And so they have what's called villus atrophy, or they don't have, so they can't absorb nutrients as well because the area to absorb nutrients is lower because of the immune response. So I told you about how IgA is a type of antibody, and TTG, or tissue transglutaminase, is an enzyme that helps in protein digestion. So when we have an IgA antibody against this enzyme, that's found in about 98% of people with celiac. So in about 2% of people with celiac disease, they're not going to have blood testing suggestive of celiac. So if we are really worried about celiac disease, a GI scope with biopsies is really the only way to definitively diagnose. And in fact, the current recommendation remains that even if their blood screening is positive for celiac disease, they still should go to GI and get biopsies done to definitively make sure they have that diagnosis, because the treatment is a lifelong dietary change, which can be hard to do. It's gluten is found in a lot of products, and a gluten-free diet is hard to do. And so we want to make sure they truly have that diagnosis before subjecting them to a lifelong dietary change like that. When we look at people with Down syndrome, if we were to screen everybody with Down syndrome with a TTG IgA antibody like we saw in this patient, about 15% of them will have a positive screening, but most of those are going to be asymptomatic, and there really is no known benefit for people with Down syndrome from restricting their diet. And so it's important for us to recognize that the current recommendation saying symptomatic only should you be testing is because of that, is that even if they have a positive screen, it doesn't mean that they're ever going to have any symptoms related to celiac. So maybe it's better not to know that they have a positive screen because they're not going to have any symptoms. That's kind of how that was. And then because the child had a normal or negative testing at 2 years of age, that can change over time. So anytime there's a new symptom that would go along with celiac disease, then we would repeat the testing at that time. Okay, just a few more slides and then we'll have questions. So we're not going to spend a lot of time on these. This is in a few weeks after the clinic visit. Then the child has now developed frequent urination, increased thirst, increased hunger, and vomiting over the past 24 hours, just really looking ill. And these are the labs that came back. So this is what we call our BMP, or basic metabolic panel. It looks at all of the electrolytes that we have in our body. It looks at our kidney functions. And also, look at that, it shows that his glucose is really elevated to 335. These labs fit with what we call what would be considered diabetes, and this specifically, these labs being also markedly abnormal, would fit with what we call diabetic ketoacidosis, which is the DKA is what that's called. And this is how we would typically see somebody with type 1 diabetes presenting. As the time goes by, their body starts to go into a shock kind of state called DKA, and that's what we're suspecting for this child, especially with these labs. Type 1 diabetes is 3 to 4 times more likely in Down syndrome than in the general population. The high blood glucose causes spilling of the glucose into the urine, which is why they pee so frequently. And then it presents with DKA and dehydration, which is what we saw in this patient. And then definitely requires specific endocrinology management with insulin, dietary modifications, etc. So something that we definitely keep in mind. Type 1 diabetes is another type of autoimmune condition. So like we've been talking about with everything almost today, thyroid and celiac disease, diabetes is also on the list of things that we see more frequently as an autoimmune condition in people with Down syndrome. Okay, now this is, I think, our last case scenario update before we go to questions. This patient now returns 5 years later as a 10-year-old, has gained a lot of weight in that time period, going from the 50th percentile to much greater than the 97th, which is the highest line on the growth chart that we can see. So this child has really gained weight very rapidly. And here are the labs. So these are liver function tests, the AST and the ALT, and they're both elevated in this patient who's had this rapid weight gain. And this is something that we're recognizing more and more as an issue in our patients who perhaps are struggling with maintaining their weight. This is what we call non-alcoholic fatty liver disease, or NAFLD, sometimes it's called. This is not very well understood, but essentially this is liver injury due to fatty deposits that are found on the liver. You can see them on ultrasound, but you can definitely see this in the lab. It is more common in Down syndrome, particularly with obesity, but remarkably, even those with Down syndrome who are not obese can sometimes have these fatty liver deposits on their liver. So again, an area of research at this time, not fully understood. It can lead to permanent liver damage, even liver failure. And the management for most of these patients is going to be diet and exercise changes with hopefully some element of weight loss coming about it because of that. And then the liver function tests do tend to return to normal. Okay, so very, very quickly to let you know, here's our group, many of our group. This was at the last buddy walk that the Down Syndrome Association of Pittsburgh has. We are so grateful for the ability to work together with our local group here at the Down Syndrome Association of Pittsburgh. In fact, as many of you may know, is the reason why our center even exists. It's 35 years this year that we've existed. That's because 35 years ago, families in the area said, hey, we would like to have a clinic. And that's how this all began. And you can see our team has definitely grown from where it started, where it was just one doctor and a coordinator. Now we have definitely grown because of the philanthropy that we've been able to receive from many organizations, including the Down Syndrome Association. So here's, if you want to get more information or get in touch with us, here's a slide that will give you that information. You can see our contact info there, some helpful websites that can give you reputable information, because everybody knows the internet is full of not so reputable information. So want to make sure you guys have that. If you want to give directly to our center, the link is there as well, that you can give through the Give to Children's website. And then a podcast that we do that hopefully many of you are aware of, but if not, come join the over 250,000 people who have downloaded, or 250,000 downloads that we have had of the podcast. We have, I think, 171, maybe one released this morning, even, I think 172 podcasts that have gone out on any number of topics. So if you want to find out more about what we talked about today, yeah, any of the medical issues, please do check out the podcast on any of your favorite podcast apps or websites. And this is me and my brother. He is my inspiration for what I do. He will be turning 49 in a month. I can't believe that. And so excited to be able to give back to him because of how much he has given me. So feel free in whatever way you want to ask questions. I'll leave this up. You can ask using that app, or you can put it in the chat, or whatever you want to do. And I will stop presenting at this point, and wait to hear what you want to say, or what you want to ask.
Thank you so much, Dr. Vellody. That was a fantastic presentation. And just so everybody knows, it is recorded, so we'll have it on our website under Speaker Series recording. So we'll have it uploaded and then it'll be there. So thank you again. This was fantastic.
So
And
I
we,
do.
go
Oh,
ahead.
go ahead. I was going to say I do see one question
Yes,
on
move
here,
right along.
which is a great question for those who are maybe on a phone or you can't see it. It says, should liver function tests be done as part of the annual blood work for children with Down syndrome, or only if there has been a significant weight gain? So, and then there's a second question, but let me just answer this question first. So this is a really hard question to answer, because I think in the study I had referred to in the slides, probably came out about 4 or 5 years ago, out of a group in Italy, who I think is the first group to actually look at this specifically in Down syndrome. And very surprisingly, they discovered this non-alcoholic fatty liver disease, especially in people with who struggle with weight gain and with Down syndrome, but even in those who weren't. And that was surprising for us. And so your question is good. And I don't have a guideline-based recommendation for that, but I do wonder if perhaps as our kids become teens, if this might be something that you start to see us doing more often, just to screen the liver function, to make sure that that they're not showing any signs of inflammation there. And then second half of the question was, I would love to hear about cholesterol labs. Oh yes, you know what? I'm going to add one about cholesterol. That's a great question. So surprisingly enough, there are medical benefits to having an extra 21st chromosome. One of those benefits is the fact that people with Down syndrome, even into their adulthood, do not seem to get cholesterol plaques on their arteries around their heart, so their coronary arteries. So for those of us on the call without Down syndrome, that started when we were probably 4 or 5 years old. We started depositing cholesterol plaques in our coronary arteries. I know that's kind of freakish as you're sitting there eating probably your lunch, but it's true. But in people with Down syndrome, even if they're 65 years old and they die of whatever other reason, if you were to look at their coronary arteries, they would be crystal clear. They don't have any cholesterol in them. And nobody knows why. There must be something on the 21st chromosome that is protective against getting cholesterol plaques on those arteries. So as I've talked with Dr. Bulova in our adult center, Dr. Chacoin also in the adult center in Chicago, it is not routinely recommended that cholesterol needs to be screened in adults with Down syndrome when we're thinking about coronary artery issues. They just don't seem to get it. And so we do see high cholesterol levels, don't get me wrong, but they don't seem to be causing any cholesterol-related plaques in their heart. So it's a phenomenon that I think, boy, if we could package that and put that into a pill, I'm sure that some drug company would love to make that drug that would protect all of us in the same way that our friends with Down syndrome seem to be protected against coronary artery disease. So great questions. What other questions do you have? Oh, thank you for being an avid listener to the podcast. And would love for anyone on this call, even if you have questions that you want us to answer on the podcast too. Like that's, after 172 episodes, I'm starting to wonder, what do I do? What's left? There's only so many times I can talk to myself on the podcast. So if there are topics I haven't covered yet, or you want me to cover again, by all means, reach out. Any other questions at all? Oh, good. Okay. Question coming with my son is turning 18 next month. Is there anything we should be looking for as he ages? Great question. And I think when Dr. McCormick comes on, Masha, do you remember what date that is that he comes? Um, we
Yes,
can
he will be on February 9th, Friday, February
Perfect.
9th, 12 to 1.
Definitely ask Dr. McCormick on February 9th his thoughts on this. But certainly, as the kids become adults, there's a lot to look out for, not just medically, but otherwise too, right? So a lot of people don't realize that when your child becomes 18, whether they have Down syndrome or don't have Down syndrome, in the law, they are an adult. Which means that if you bring your 18-year-old and one day quote unquote child to the ER, and the ER says, okay, we need to get an X-ray, looking for pneumonia or whatever. And they say, no, I don't want an X-ray. It doesn't matter that you've been their parent for 18 years and you've been their medical decision maker for 18 years. They are 18. And if they say no, they say no. And the doctors can't do it. So there's things to get prepared for. Things like, should we be seeking things like medical power of attorney or guardianship that is going to be important to talk about. There are things like, hey, grandma says they want to leave in the estate, they want to leave money in Johnny's name, and Johnny has Down syndrome, let's say. Well, the government will look at that as income for Johnny, and Johnny will lose all of his health benefits. And so that's something to think about. Okay, maybe there's a special needs trust that needs to be created that can be a place where you can put that. If you're saving money for your child, perhaps for education, they want to go to college and do one of the college programs that are over 300 of them around the country that are specifically for folks with intellectual disability. But if you save that in their name, that will be looked at as estate or income for your young one with Down syndrome, which again, you have the ABLE Act that allows us to save money that way. So lots of things to consider, which is why we have a transition clinic as part of our Down syndrome center where they answer those questions, medical and beyond, when it comes to that. But I don't want to answer too many. I think that's a good primer to get you hopefully excited to go and listen to Dr. McCormick in February. Okay. Oh, part two. Part two for the cholesterol is 10-year-old has high triglycerides. Other cholesterol levels are normal. Our triglycerides usually high. So triglyceride in general, not even specific to Down syndrome, triglycerides tend to be elevated in people from a dietary intake perspective. So if you eat I don't know, a large steak or whatever, and eat a ton of fat as part of that, and you check your triglycerides in the next couple of days, they're going to be high. Okay. So it's based on your dietary intake most often. And so the most important thing when somebody has high triglyceride levels is really as much as we can to foster a healthy diet options. And I know I say as much as we can because it can be hard, but I think that would be definitely something that would need to be looked at. Now, maybe there is a great diet and there's other things going on. I'm not sure. I'm not answering, specifically to your child, but that would be definitely something that I would look into is maybe even we have a nutritionist now through the center, a dietitian. So if you did want to get some advice, that would definitely be something that you could do is call us and we can help you get connected with our dietitian.